Diffuse large B-cell lymphoma, DLBCL. Under microscopy, the cytologic features of diffuse large B-cell lymphoma, DLBCL, with CD20 expression can be described as follows. DLBCL cells are typically larger than normal lymphocytes and have a variable appearance. The cells may exhibit a diffuse growth pattern without the nodular architecture seen in some other lymphomas. The nuclei of DLBCL cells are often large, irregular, and pleomorphic, showing variability in size and shape. Nucleoli may be prominent, and the chromatin pattern can be coarse. The cytoplasm of DLBCL cells is variable and may range from scant to moderate in amount. Cytoplasmic borders may be indistinct, contributing to a more blastic appearance. DLBCL cells express CD20, a B-cell marker, as well as other B-cell markers such as CD19 and CD79A. Immunohistochemistry is used to identify these markers, and the expression of CD20 is particularly relevant in the context of targeted therapies like rituximab. Hematoxylin and eosin, H&E, staining may reveal the characteristic large and pleomorphic cells infiltrating tissues, such as lymph nodes or extranodal sites. Immunohistochemistry staining for CD20 will show positive membrane staining of the tumor cells, confirming their B-cell origin. DLBCL is characterized by a high mitotic rate, reflecting its aggressive nature. High mitotic activity is often evident upon microscopic examination. It's important to note that DLBCL is a heterogeneous disease, and there can be variations in the microscopic appearance between different cases and even within the same case. Additionally, the World Health Organization, WHO, classification recognizes molecular and genetic subtypes of DLBCL, each with distinct characteristics that may influence treatment decisions and prognosis. Therefore, a comprehensive evaluation, including molecular and genetic profiling, is often performed to provide a more precise diagnosis and guide treatment strategies. Epidemiology of diffuse large B-cell lymphoma CD20+. As of my last knowledge update in January 2022, diffuse large B-cell lymphoma, DLBCL, is the most common subtype of non-Hodgkin lymphoma, NHL, and it is known for its aggressive behavior. Here are some key aspects of the epidemiology of DLBCL, particularly when considering CD20 expression. Incidence. DLBCL accounts for a significant proportion of all NHL cases. The incidence of DLBCL increases with age, and it is more commonly diagnosed in older adults. However, it can occur at any age. Age and gender distribution. DLBCL can affect individuals of any age, but the risk increases with advancing age. The median age at diagnosis is typically in the 6th and 7th decades of life. DLBCL is slightly more common in men than in women. Geographic variation. DLBCL is found worldwide, and its incidence can vary across different geographic regions. Certain subtypes of DLBCL may show geographic variations, possibly reflecting differences in underlying risk factors or genetic predispositions. Association with immunodeficiency. DLBCL is more common in individuals with immunodeficiency, such as those with HIV/AIDS or in the setting of post-transplant immunosuppression. In HIV-infected individuals, DLBCL is considered an AIDS-related lymphoma. CD20 expression. The majority of DLBCL cases express CD20, which is a B-cell marker. CD20 expression has therapeutic implications, as it allows for the use of anti-CD20 monoclonal antibodies such as rituximab in treatment regimens. Molecular subtypes. DLBCL is a heterogeneous disease with molecular and genetic subtypes. Molecular profiling has identified distinct subgroups, such as germinal center B-cell-like, GCB, and activated B-cell-like, ABC, DLBCL, each with different clinical characteristics. Risk factors. While the exact cause of DLBCL is often unknown, Some risk factors may include genetic predisposition, certain infections, e.g., Epstein-Barr virus, autoimmune disorders, and exposure to certain chemicals or environmental factors. It's essential to note that epidemiological data can change over time, and new research may provide additional insights into the incidence and characteristics of DLBCL. For the most current and region-specific information, it is recommended to refer to recent medical literature or consult with healthcare professionals and relevant health agencies. Physiopathology of diffuse large B-cell lymphoma, DLBCL. The physiopathology of diffuse large B-cell lymphoma, DLBCL, involves a complex interplay of genetic, molecular, and environmental factors that contribute to the development and progression of this aggressive B-cell lymphoma. Here is an overview of the key aspects of DLBCL physiopathology. B-cell origin. DLBCL arises from mature B cells, specifically from the germinal center B cells or post-germinal center B cells. These cells undergo genetic mutations and acquire abnormalities that lead to uncontrolled proliferation and escape from normal regulatory mechanisms. Genetic abnormalities. DLBCL is characterized by a high degree of genetic heterogeneity. Common genetic abnormalities include chromosomal translocations involving oncogenes and tumor suppressor genes. For example, translocations involving the BCL6, BCL2, and MYC genes are frequently observed. MYC rearrangements, especially in conjunction with BCL2 or BCL6 rearrangements, double-hit or triple-hit lymphomas, are associated with aggressive disease and poorer prognosis. Cell cycle dysregulation. Aberrant regulation of the cell cycle is a hallmark of DLBCL. Genetic alterations often lead to the dysregulation of cell cycle checkpoints, promoting uncontrolled cell division and proliferation. B-cell receptor, BCR, signaling. DLBCL cells may exhibit dysregulated B-cell receptor, BCR, signaling. Abnormalities in components of the BCR signaling pathway can contribute to sustained activation and survival signals, promoting lymphoma cell survival and growth. NF-kappa B pathway activation. The NF-kappa B pathway is frequently activated in DLBCL. NF-kappa B signaling is involved in the regulation of cell survival, proliferation, and immune responses. Dysregulation of this pathway contributes to the survival and growth of DLBCL cells. Tumor microenvironment. Interactions with the tumor microenvironment play a crucial role in DLBCL pathobiology. Stromal cells, immune cells, and extracellular matrix components within the microenvironment can influence the behavior of DLBCL cells. Epigenetic alterations. Epigenetic changes, including DNA methylation and histone modifications, contribute to the regulation of gene expression in DLBCL. These alterations can affect the expression of key genes involved in cell cycle control, apoptosis, and other cellular processes. Epstein-Barr virus, EBV, infection. In a subset of DLBCL cases, particularly those with immunodeficiency, infection with Epstein-Barr virus, EBV, may play a role in lymphomagenesis. Understanding the physiopathology of DLBCL is crucial for developing targeted therapies and personalized treatment approaches. Advances in molecular profiling and genetics studies continue to refine our understanding of DLBCL heterogeneity, paving the way for more precise diagnostics and therapeutic strategies. Clinical manifestations of diffuse large B-cell lymphoma, DLBCL, can vary widely, and they are often influenced by the site of involvement, the extent of disease, and the presence of systemic symptoms. Here are the key clinical features associated with DLBCL. Lymphadenopathy. The most common presenting symptom is painless, rapidly enlarging lymph nodes. Lymphadenopathy can occur in any part of the body but is often observed in the neck, axilla, and inguinal regions. Extranodal involvement. DLBCL frequently involves extranodal sites, such as the gastrointestinal tract, bone marrow, central nervous system, skin, and other organs. Extranodal involvement may cause specific symptoms related to the affected organ. For example, gastrointestinal involvement may lead to abdominal pain, nausea, or changes in bowel habits. B symptoms. B symptoms refer to systemic symptoms that may indicate more aggressive disease. These include fever, unexplained by other causes, night sweats, and unexplained weight loss, usually exceeding 10% of body weight over the preceding 6 months. Compression symptoms. Depending on the location of the tumor, DLBCL can cause compression symptoms. For example, mediastinal involvement may lead to cough, chest pain, or superior vena cava syndrome. Bone marrow involvement. Bone marrow infiltration can occur, leading to cytopenias, low blood cell counts, which may manifest as fatigue, weakness, or increased susceptibility to infections. Central nervous system involvement. In rare cases, DLBCL may involve the central nervous system, CNS. CNS involvement can lead to neurological symptoms, such as headaches, confusion, seizures, or focal neurological deficits. Generalized symptoms. Some patients may experience nonspecific symptoms such as fatigue, malaise, and generalized weakness. It's important to note that the clinical presentation can vary widely among individuals, and not all patients will experience the same symptoms. Additionally, DLBCL is a heterogeneous disease, and different molecular subtypes may have distinct clinical characteristics. The presence of certain risk factors, such as advanced age and the presence of B symptoms, may influence treatment decisions and prognosis. If DLBCL is suspected, a thorough clinical evaluation, including imaging studies, biopsy of affected lymph nodes or extranodal sites, and laboratory tests, is necessary for accurate diagnosis and staging. Prompt diagnosis and appropriate treatment are crucial for achieving the best possible outcomes. Treatment typically involves chemotherapy, often combined with immunotherapy, such as rituximab, and may include additional modalities such as radiation therapy in certain cases. Prognostic factors in diffuse large B-cell lymphoma, DLBCL, are clinical or biological characteristics that provide information about the likely course of the disease and help guide treatment decisions. Several factors influence the prognosis of DLBCL, and they are often used to assess the risk and tailor treatment strategies. Here are some important prognostic factors. International Prognostic Index, IPI. The IPI is a widely used prognostic tool in DLBCL and other aggressive lymphomas. It considers 5 factors: age, greater than 60 years versus less than or equal to 60 years, performance status, 0 to 1 versus 2 to 4, stage, 1 to 2 versus 3 to 4, serum lactate dehydrogenase, LDH, level, normal versus elevated, and the number of extranodal sites involved, 0 to 1 versus greater than or equal to 2. Patients are categorized into low, low intermediate, high intermediate, and high risk groups based on the presence of these factors, with higher IPI scores indicating a worse prognosis. Cell of origin, COO, classification. DLBCL can be classified into different subtypes based on gene expression profiling, including germinal center B-cell-like, GCB, and activated B-cell-like, ABC, subtypes. The ABC subtype is associated with a poorer prognosis compared to the GCB subtype. Molecular features. MYC and BCL2 BCL6 rearrangements, co-expression of MYC and BCL2 or BCL6, known as double-hit or triple-hit lymphomas, is associated with a more aggressive clinical course and poorer outcomes. p53 mutations, TP53 gene mutations are associated with resistance to standard therapies and a worse prognosis. Ki67 proliferation index. The Ki67 proliferation index measures the percentage of cells actively dividing. A higher Ki67 index is associated with more aggressive disease and may be indicative of a poorer prognosis. Extranodal involvement. The presence of extranodal involvement, especially in specific organs or tissues, may influence prognosis. Involvement of certain extranodal sites, such as the central nervous system, carries a worse prognosis. Serum beta-2 microglobulin. Elevated levels of serum beta-2 microglobulin, a marker of tumor burden, are associated with a poorer prognosis. Early treatment response. Response to initial therapy is a crucial prognostic factor. Patients who achieve a complete remission after first-line treatment have a better prognosis compared to those with persistent disease. Age-adjusted International Prognostic Index, AAIPI. A modification of the IPI that considers age as a continuous variable rather than a dichotomous one. Incorporates age as a continuous variable, providing a more nuanced assessment of risk. It's important to note that the evaluation of prognostic factors is an evolving field, and ongoing research may identify additional markers or refine the significance of existing ones. The comprehensive assessment of these factors allows oncologists to stratify patients into risk groups and tailor treatment approaches to optimize outcomes. Individual patient characteristics and response to therapy also play critical roles in determining prognosis and treatment strategies. The treatment of diffuse large B-cell lymphoma, DLBCL, typically involves a combination of chemotherapy, immunotherapy, and in some cases, radiation therapy. The choice of therapeutic methods depends on various factors, including the patient's overall health, disease stage, molecular characteristics, and response to initial treatment. Here are the main therapeutic methods for DLBCL. Chemotherapy. R-CHOP regimen. The most common and widely used chemotherapy regimen for DLBCL is R-CHOP, which includes the following drugs. Rituximab, are a monoclonal antibody that targets CD20 on B cells. Cyclophosphamide, C an alkylating agent. Doxorubicin, H an anthracycline. Vincristine, O a vinca alkaloid. Prednisone, P a corticosteroid. Immunotherapy. Rituximab, rituximab is a monoclonal antibody that targets CD20, a B-cell marker. It is often combined with chemotherapy, R-CHOP, and has significantly improved the outcomes for DLBCL patients. Polatuzumab vedotin, POLIV. This is an antibody-drug conjugate targeting CD79B, which is expressed on B cells. It may be used in combination with bendamustine and rituximab for certain cases. High-dose chemotherapy and stem cell transplant. For eligible patients, especially those with relapsed or refractory disease, high-dose chemotherapy followed by autologous stem cell transplant, ASCT, may be considered to improve outcomes. Targeted therapies. BTK inhibitors, e.g., ibrutinib. These are targeted therapies that inhibit Bruton's tyrosine kinase and may be used in specific cases, particularly in relapsed or refractory disease. CAR T-cell therapy. Chimeric antigen receptor T-cell therapy involves modifying a patient's own T-cells to express a receptor targeting CD19, a B-cell marker. CAR T therapy is reserved for relapsed or refractory cases. Radiation therapy. Localized radiation therapy may be used to target specific areas of involvement, especially for limited-stage disease or to address specific symptoms. Central nervous system prophylaxis. In some cases, particularly for high-risk patients, measures to prevent central nervous system involvement may be considered, such as intrathecal chemotherapy or systemic therapy that penetrates the blood-brain barrier. Supportive care. Supportive care measures, including antiemetics, growth factor support, and antibiotics, are often provided to manage side effects of treatment and prevent complications. Clinical trials. Participation in clinical trials may be considered, especially for patients with relapsed or refractory disease or for those who are candidates for novel therapies. The choice and sequencing of these therapeutic methods depend on the specific characteristics of the individual patient and the disease. Treatment decisions are typically made in consultation with a hematologist-oncologist, taking into consideration factors such as age, overall health, comorbidities, and the presence of specific molecular features. Advances in understanding the molecular basis of DLBCL continue to inform the development of new therapeutic approaches, and ongoing research aims to improve outcomes for patients with this aggressive lymphoma.